So I'm Tony Marson. I'm a professor of neurology at University of Liverpool. But my history is in running research projects to try and inform decisions that are made in the NHS, doing some of the clinical trials that were mentioned earlier, as well as more recently work trying to inform day-to-day clinical decision-making and how services operate. I'm sure Keith will tell you a little bit about his background, but over the next half an hour or so, Keith and I are going to do a bit of a double act, and hopefully there'll be lots of time for questions. When I looked at the programme, I realised that Keith and I have been billed as the bad guys, I think. Keith and I are the problem. I'm sure that's not the case, but to an extent, Keith and I will be giving a bit of a reality check about what it's like working in the health service and changing things in the health service, because it's a huge organisation, and there may be a bit of naivety around what can be done and what can be achieved in what is a really short time frame for the NHS. So as clinicians, we're presented with problems and we like to fix them. So my brain works in this way. What's the problem? How can we fix it? And what we really want to do is do something that improves patient outcomes and does something about inefficiency in the health service. And of course, something that's going to improve the quality of what we're doing. And if we can't do this, I think we're wasting our time. We're involved in a construct that has little usefulness about it. We really must be doing something that's going to deliver something that is important to the public and patients within the NHS, improving outcomes and improving efficiency within the services. Clearly, we can't do that for the whole of healthcare in the Northwest Coast, and we have to focus on something. And when we put the bid together, we decided that we would focus on two broad areas. One was unplanned care, and that was a no-brainer because unplanned care is in the news all the time as a problem. Our emergency departments are really struggling to cope with demand. But emergency care is massive, and we need to focus on specific pathways to work on. And when we thought about this, we thought that we need to be thinking about conditions where there is interaction between multiple care providers, so the emergency departments, hospital clinics, and general practice, for example. And so it kind of made sense to be thinking about chronic diseases. So can we improve the management of chronic diseases such that there is reduced load? There's a less chance that people are going to end up in the emergency department. We have some early wins around epilepsy, and I'll talk about that later because of some ongoing work which we can immediately add value to through connected health cities. Chronic obstructive pulmonary disease, which is what COPD stands for, is a big problem in the Northwest Coast, and it made sense to try and pick that big ticket item to try and improve outcomes and health service efficiency. The other area that we decided to work on was upon alcohol. Alcohol, again, a massive problem in the Northwest Coast. And we need to do something to improve outcomes and access to services. And the way that alcohol affects individuals means that there's an opportunity there to bring in a really wide set of data sets, including social care. And Keith will tell you a lot more about that during his part of this session. Keith and I and others have produced a kind of outline of what it is that we want to do over the next couple of years, and there are three main steps. And I'm just going to tell you about the first step, and Keith will introduce the second and the third step during his talk. What we want to do first of all is use data that is potentially readily available, and of course we're heavily dependent upon other bits of connected health cities to get access to the data, particularly through the team at AIMS. What we want to do is start with something called hospital episode statistics, and we want to link that to other data sets such as GP prescribing and investigation results. so blood test results, scan results. Can we work towards linking just these three main areas? Although it's likely that our first steps are going to be made purely based upon hospital episode statistics data. John Ainsworth highlighted what a learning health system looks like. This is how we've envisaged it, so I'm going to show you a cycle that is very similar to the cycle that John showed you. If I press the right buttons, or it's, okay. Going in reverse. Am I pointing it in the right direction? There we go. Okay, right, I was pointing it at the floor rather than at the receiver. What's fundamental is that we're able to engage the clinical community. And my guess is there aren't many clinicians here. And so we have a completely different audience to engage with to try and make this work. And if we're going to do something that's going to be useful within the health service, clearly we need to be engaging with clinical communities. And Keith and I and Mike and others have got a major job on our hands to try and engage with our clinical partners to enthuse them about the ideas and try and make things happen. Those conversations with clinical partners, of course, will lead to the identification of problems and questions that we need to address, particularly within patient care pathways. And once we've identified those problems, we can think about how we want to analyze the data. And again, there is sometimes a clash of cultures. There are people that start with the data and say, what questions can we sort out with this data? I come from a very different culture. What's the question? What's the best design to answer that question? And then how do we analyze these data to answer those questions? We have to start off with sensible questions. If we start off with data and start playing with it, we end up going down all sorts of garden paths and end up doing something that's not as useful as we would like. So we really need to start with engaging with the clinical community, identifying those important questions and using the data sensibly to answer those questions about what